Today we have Vaitheeswaran Lalgudi here. He's our new fellow, but he's got quite a bit of experience in many aspects of refractive and corneal surgery. And we're really lucky to have him here talking to us today, and I'm looking forward to learning from him over the next couple of years while he's in Ottawa. Vaitheesh did his medical school in India and Pondicherry, and then went on to do residency at the famed Ames Institute, and then went on for some fellowship training in Bangalore. Now has been there for the last 4 years or so. And we are lucky to have him here. He just started. I met him for the first time this past weekend, physically in person. So welcome, Vaitheesh. And of course, his topic today is going to be revolving around how we treat some of the corneal pathologies. And so without further delay, Vaitheesh, please start your talk. We're looking forward to hearing what you have to say.
Sure. Sorry, yeah. Good morning, everybody. Thank you, Dr. Keshav, for the introduction. And it's really exciting to be here as well. And I'm looking forward to learning and teaching and discussing a lot from here on. And this topic for today is going to be on the novel Excimer lasers in keratoconus and corneal scars. Yeah. So to start off with this topic, I would like to have, say a broad disclaimer saying that it's not going to be a traditional class on Excimer lasers where, you routinely understand how Excimer lasers work and how to, use them and all that. So it's going to be a slightly departed lecture from that concept, wherein we would touch upon these objectives from here on. As in, we would first need to understand the use of Excimer lasers in the management of keratoconus. What is their current position and how did they evolve to the current position? And to also understand what novel possibilities exist, and is there a proof of those concepts which claim novelty? And then go on to study the extension of these applications to the other areas of as in corneal scars as well. So to start off with, this is something which is an age-old slide which shows about what cross-linking does and what it offers to the to patients with keratoconus. And looking at it, it's something that everybody understands that cross-linking is going to stabilize a disease and prevent it from progressing further. But as far as visual rehabilitation of these patients with, say, moderate to advanced keratoconus are concerned, it's much beyond cross-linking. This is something which is really something which is lucid to everybody in this current scenario right now. And rightly, there are new procedures that came up in the last 10 to 15 years which spoke about visual rehabilitation. So before we go into those areas, we would have we'll have a first poll question to understand what your current understanding about all these is before we kind of go ahead and discuss all of them one by one. Vicky, can we have the first poll question, please? Yeah, so this question is for all of you to answer. It has multiple choices. You can choose as many as you feel are the right options, and we'll have your polls to see how the situation stands. So we'll give another 10 seconds for people to answer this before we look at the results and proceed further. Yeah, so can we have the results? Yes. So that's great. There's a lot of people have answered most of them, and though Cretan and Nathan's protocol are one of the most commonly used ones. So yeah, we would discuss what each of these mean actually to rehabilitation of vision for visual for keratoconus patients. Yes, so intrastomal rings has got the maximum response. Yes, that's one existing system right now, but it is not in isolation anymore. It's also in combination with other things that is being used. So the first thing that people answered was about Cretan protocol. So what Cretan protocol basically means is, if This, apart from cross-linking using a manual epithelial removal, either using alcohol or with manual debridement, when you do a PTK to remove the epithelium and then proceed on with the cross-linking, which is your Cretan protocol by the Palicaris and Communist groups. And basically, compared to whatever cross-linking could offer, Cretan protocol offered a slightly better visual outcome compared to the manual epithelial removal. And they also studied and they found out that the endothelial cell damage was not there. And before we discuss Cretan protocol, we'll have another question, the poll question number 2. In order to find out from you all, what is your idea about how Cretan protocol fares better over the manual epithelial removals? Can we have the second question? Yes. So PTK done before cross-linking has a better visual gain over manual epithelial removal for the following reasons. So you would have to choose only one. So if the answers have been polled, we can have a look at what people feel about the reason. Wow, it's so amazing to know that people are already in sync with what we are going to be discussing. So it's definitely not because it's built separately. It definitely has an effect on what it brings out to the vision. So it additionally ablates some stroma and induces flattening. So basically, if you look at this next slide here, if you looked at this topography, which suggests, which shows you an early keratoconus with inferior cone. If you look at the epithelial thickness in that area itself, you will be able to find that in most of the cases, you will be able to have an epithelial thinning in the region of the cone. So what basically it does is, if you ablate a 50 or 60 microns of PTK in the region of the cone where the epithelium is thin, you're also going to be ablating a little bit of the stroma, and in effect induce a little bit of flattening in the region of the cone, which is what you actually desire. And so rightly so, it's because it's a PTK and it is going to be predominantly useful for central cones, because as you go towards the periphery, this effect of PTK is going to decrease, because that's the right reason why normal PTK, if it is done without an adjustment for the spherical error that is induced, you normally have a hyperopic shift because it ablates more in the center and ablates less in the periphery. So if you are looking at treating a peripheral cone, if you're just going to do a regular PTK for the Cretan protocol, you're not going to have as much ablation of the stroma under the cone as you would expect in a central cone. And additionally, if you have, say, a PTK of 50 microns thickness, if the difference between your PTK thickness and your minimal epithelial thickness, for example, over the cone is, if you have a 30 micron epithelial thickness over the cone, you would have a 20 micron ablation. Whereas if you had a 48 micron epithelial thickness over the cone, you would only have a 2 micron of stroma ablated. So there is a region of unpredictability, and you cannot customize it, and you cannot use it for peripheral cones. So that was one disadvantage of Cretan protocol, and it obviously did not give you a very good unaided vision and best corrected vision as in your Athens protocol, which is basically your doing a topo-guided PRK and then following it with the cross-linking. So what you basically do here, in addition to Cretan protocol, is you basically do a full TCAT protocol, or you just correct for all the aberrations in the cornea, and it treats an area over 6 to 6.5 or 7 millimeter optical zone, and it corrects the entire aberrations. And most people tend to also correct, if you look at the grayish circle which is superimposed on the figure, you will be able to see that it ablates an area a lot more than whatever is the area of the cone and whichever area actually desired to have an effect on. So it's going to be treating a lot of more surface area, a lot of more volume, and a lot of more depth, and it's going to definitely produce a really good visual outcome. So most people have been, after topo-guided PRKs, their unaided visions have been equal to or better than 20/40. So it's definitely one of the best ways of current modes of rehabilitation of these patients. But if you looked at this option again, that how much to treat, how much cylinder to treat, which axis to treat, these are questions which are ongoing, starting from the initial inventions or discoveries by the Canalopolis group, the other protocols which came up for which cylinder to treat, how much to treat. The debate is still ongoing to the level of 4 cities, So though they have been planned for normal corneas, but the same rule holds good when you even plan for a irregular cornea as to which cylinder to treat, whether you want to treat the corneal cylinder or whatever the patient manifests, or what is inside or the internally, and how much to treat is a big question. So if you ablate a lot, it's not very safe. So that takes us to the next poll question, number 3. In order to find out what your current understanding of topographic PRK or Ethan's protocol is. So, which are true regarding ablating stromal corneal tissue in keratoconus. So, we would like to have your responses to see what your current understanding of going ahead with the topographic PRK is. And after a few seconds, we'll have the responses polled. So can we have the results? Oh, that's amazing. So yeah, it's rightly so. As well, the school of thoughts are divided on these. We have our audience also divided in the same proportion. So many people outside feel, a significant group of people feel that it's absolutely safe, and no matter how much ever depth you ablate, and group feels it is absolutely contraindicated, and they say you cannot ever ablate the stroma in a keratoconic eye. So there are both schools of thoughts, and the basic final whatever I want people to have at the end of this talk is the option C and D, which is basically it is definitely safe when the ablation of the corneal thickness is when the corneal thickness after the ablation is at least 390 microns, which is epi off. And the other factor that we also have to remember is that the long-term outcomes are still not known. So if we have this idea, we can proceed on to the further discussion of why we require something more. So the hypothesis here is, if you looked at this image which was previously shown, if you look at the grayish circle over the tangential anterior curvature, you would find that it ablates a lot of area and ablates more volume and surface area as well. And though we may think it is safe, but it is always, our attempt should be towards minimizing the depth and surface area and volume of ablation and balancing it out with the visual rehabilitation or the level of visual gain that we have. So instead of having it at the center, which is normally how PTKs and PRKs work, as in your ablation is centered on the vertex of the cornea. Instead of it, if you can displace your vertex and you can decrease your area of ablation to exactly the area of the cone wherever you want the desired effect to happen. If that is possible to customize, then it would be really amazing. So that's something that we are going to look ahead from here. I'm sorry for the words have come out of the slide. I don't know if there's a little bit of difference in the organizing. Okay. So if we can localize this basically from the center, and instead of having a larger area, if we can decenter the ablation to the area of the cone, then what we'll essentially be doing is we can effectively have a decreased surface area and volume of ablation, and also customize the depth of ablation. As in, we discussed in a Cretan protocol that if your epithelial thickness in the area of the cone is 40, you will effectively be able to ablate only 10 microns if you do a 50 micron PTK. But what in essence you can do, if you can customize here, it's for example, your epithelial thickness over the area of the cone is 50, you can still treat say 70 or 75 microns of PTK in that specific area and not worry about how much of ablation would happen to the rest of the cornea. So is this possible? So this is something called a TREC, which is a topographic removal of epithelium. So this is possible, and if you look at what is new here, as we discussed, if you look at the Schwinn series topographer, you can actually find out, even in any topographer, you can find out the location of the K-max, and you can also measure the axis of the cone, long and short axis. And after that, once you transfer these details to your Excimer laser, what you will be able to feed in is your epithelial thickness in the region of the cone, your ablation depth in accordance to that, and in combination of all these three things, with your long axis and short axis of the cone, with your ablation depth and your offset, which is the decentration of the ablation to the center, what you'll effectively be able to plan is an ablation which I have shown in ragged red margins. And if you actually finally look at the ablation, what happens, it happens exactly over the area of the cone. So you will be able to customize your depth of ablation based on the epithelial thickness that you have in that region. You can feed in the epithelial thickness and add how much of extra ablation that you want, and you can specifically find out the long and short axis of the cone by measuring it on your topographers. It can be any topographer, and additionally with the position of the K max, which denotes an area close to the center of the cone, you will be able to decenter the ablation as well and treat it at any extent that you want. So yes, this is possible. So if you look at what happens on an animation aspect as well, so if you look at the cornea top end, this ablation, whatever is going to happen, is also cyclotorsion compensated as it is fed into the system. And after that, what you do is you remove the surrounding epithelium manually, and after that you add your riboflavin and do your cross-linking with any protocol that you are familiar with. And so let's see, does it work? Hypothetically, it is good. So this has been published by a group in cornea a couple of years ago on as a surgical technique of cross-linking, and as a modified PTK followed by cross-linking. So if you looked at examples of what happens, so looking at one case example where the ablation, where the cone is slightly decentered inferiorly, and if you looked at this patient, normally if this patient has an epithelial thickness of say, a corneal thickness of say 460, 470, and he would not be very suitable for an Nathan's protocol where you would be ablating close to 60 or 65 microns of stroma, then he would have an effective thickness before cross-linking of close to 300 or 350 or something like that. So what you would be able to do here in this procedure is plan the area of the ablation exactly over the area of the cone, as you can see here on the right side image, which shows you the ablation in red. And if you looked at the outcomes, the one on the left is the preoperative, the one in the middle is your post-TREC, and the one at the last column shows you the difference in the ablation. So basically what you can appreciate here is that there is a significant reduction of the vertical coma, and the topography is not completely regularized as you would expect in an Nathan's protocol or in a topo-guided PRK, but it's definitely much towards the normal compared to how it was preoperative. And if you look at the visual outcomes, the BCVA has definitely improved and the UCVA as well. And if you look at the other indices which your topographers show of keratoconus, all of them show a significant decline, be it the surface asymmetry or the aberration profile of the cornea or the RMS profile of the front and back surface, all of them show a decline, showing that basically indicating that your cornea has, the irregularity has decreased. And this is an example of a relatively central cone. And if you look at this, the ablation would also be relatively centered, though slightly decentered to accommodate the slightly inferior cone. And you can ablate to the extent that you specifically want it to be, say, 20 microns over the epithelial thickness at the level of the cone, or 30 microns or 15 microns. But we have been planning it traditionally only for 20 to 25 microns. We are yet to explore the other protocols. So if you look at the outcome of this as well, you find a significant flattening of 3 to 3.5 diopters in the center, with an improvement in the vision as well, which is explained by the decrease in aberrations. And people might wonder if there is always a question in topo-guided PRK, if you're ablating and then doing a cross-linking, is there a change in your corneal endothelium? It doesn't happen. We have studied it with the TREC procedure, and it doesn't happen. And if you look at the visual gain that these patients have, 55% have at least 2 lines of uncorrected vision gain, and 20% have at least 2 lines of CDVA gain. And it's a significant number. I do not want to compare it head on and say it's better than topo-guided PRK. It's because the amount of ablation that you're doing is obviously lesser. And even if you look at the keratometric change, normally in a simple cross-linking, you would expect around 1 to 1.5 or maximum 2 diopters of flattening, or with a cretin, you would expect it around 2.5 to 3. But here you're having a heightened keratometric change because you are able to specifically target the cone area. And looking at the aberration profile as well, you have a significant decrease in the higher order aberrations and coma, which is what determines your CDVA. And if you have to play the devil's advocate for my this own technique which I described, is the epithelial healing? Is there a problem with the epithelial healing? No, rightly so. We are documenting the changes from post-op day 1 to 3 until it healed. And if I did not say, if I don't claim it to be healing faster, I can at least still claim that it heals exactly as we used to do our manual epithelial removals earlier, that it completely heals by day 3. And not only, it's just not a healing as such. If you looked at, these are 2 images of epithelial profiles before TREC was done. These are 2 different eyes. And you can see that there is a significant epithelial variation or a thickness change on the surface. And after the procedure, if you looked at both the corneas, the epithelial profile it's much more smoother. So what you are essentially having is a decreased epithelial aberrations as well. So it's just not healing normally as any cross-linking, but it is also improving the regularity. So that long-term outcomes are still awaited. And the other aspect that I have to say is how does it compare with propagated PRK? So if you looked at the same cornea, same two plannings, one for a TREC and one for a propagated PRK, in one you'd be ablating around say 90 to 95 microns beyond the epithelium, and the other one you'd be ablating only close to 20 to 25 microns. In essence, what you're doing is ablating around 8 times lesser the volume in a TREC and obtaining visual outcomes that are similar to or which can be at least better than the other procedures that are existing. And the other aspect of comparison of how the CDVA improves is this is based on a previous comparison with our own previous paper in our institute back in Bangalore. So if you looked at TREC, the HORMs in coma have a much better improvement compared to what TPRK offers. And rightly so, TPRK has a greater decline in the defocus because you're updating for a greater level of sphere and cylinder in the cornea rather than what you're doing in TREC. And so this is a very desirable outcome. And if you looked at, can we combine it with an intrastromal rings? Because most people have answered intrastromal rings as one of the most important methods of visual rehabilitation. Yes, this procedure can be combined with an intrastromal ring as well. If you looked at this video again, this is so if you have a peripheral cone with intacts, what you basically do is flatten the area and slightly push the cone towards the center. And after a month or 3 months, if you can plan a similar TREC protocol on these surfaces, wherein you mark the the long and the flat axis, long and the short axis of the cones, and you also find out the epithelial thicknesses and feed in the values that you want to ablate. And then you can specifically ablate, comparing with the propagated PRK, which would ablate around 60-65 microns. Here you would be ablating only 20 to 25 microns in the region of the cone. And what you would additionally be doing is, after this is done, you would be going ahead with a manual epithelial removal around the area of the cone after the PTK is done for this specific area. What you will be doing is manually removing the epithelium, leaving the area over the intact rings, because normally if you have a greater riboflavin penetration in the area of the rings, there can be unpredictable exaggerated flattening because the riboflavin penetrates deep and it continues to flatten for a long period of time if your riboflavin enters your intact channels. So this is to show in an animation after the PTK is done for the area of the cone for a specified depth and a specified decentered ablation wherever you want the cone, wherever you're located the cone, you just remove the epithelium and the remaining parts, leaving the intact area, and then which is what we do manually as seen in the video. And after that, we apply a drop of riboflavin and proceed with the crosslink. So this is possible with an intact as well. So if you looked at the outcomes here again, if you look at the typical case example, the one on the top is showing a topography, which is, the initial, this is the pre-operative topography, which is the top one figure marked by A. And after just an intact ring, which was placed, a single intact ring inferiorly, you can see that the cone size has decreased and the cone has, the area below the area around the cone has flattened. And additionally, after a month of intacts, the lower figure shows the comparison between, so this is post intacts, the image in the middle. And after that, after a month of waiting, you do an eye TREC, which is basically intacts plus a TREC. And here, what you can see here is the image on the pre-operative, which is after intacts, has a significant vertical coma still, despite having the intacts. And after doing the TREC, you are having a beautiful, beautifully regular topography, which is shown in the middle, and with just 20 to 25 microns of stromal ablation. So, isn't that great? And if you look at the outcomes as well, you have over 90-95% of patients who have an uncorrected vision of, a corrected vision of more than 20/60 or 20/40 in these eyes compared to. So this is something which is a statistic which can be compared with your topography guided PRKs, wherein most studies have shown there is an 80 to 85% of patients who have an uncorrected, a corrected distance visual acuity of 20/40 or better. So we have 79.2% of them, which you can see in the lower figure. And this again is a study by a group. So it's in the final stages of revision in the Asia Pacific Journal. So, And so this is another interesting thing that we can do with Intacs followed by Trek. So the other aspect of our talk was on excimer lasers and anterior stromal scars. And if you look at this typical image, the one on the left is a pre-operative image of a corneal scar. So this patient came to us a year after undergoing LASIK elsewhere, and there was a flap complication intraoperatively, and then the center there could not manage, and they referred it to us. So basically, if you looked at the image on the right, which is the post-operative image, anybody would be able to bring this image out, by doing a PTK of the desired depth in the 6 to 6.5 millimeter zone or 7 millimeter zone, and you would be able to have this outcome. But the outcome of PTK, if you do it for these patients who are near emetropic, is that you will have a significant hyperopic shift. So since you are ablating a large area and you are ablating close to 20, 30 or 40 microns over the epithelial thickness, you would have a significant hyperopic shift in these patients. So can this be extended to this concept of a Trek or what we have renamed it as scar Trek, which is basically application of Trek for a scar, management of an anterior corneal scar. What you can specifically do here is, if you look at the image of topography below, the region of the scar, you specifically find an area of irregular astigmatism, which coincides with the region of the scar. So what we call it as topography based, we can specifically find out for that previous case in keratoconus. I pointed out that the offset or the extent of decentration of the ablation has to be to the position of the keratometric apex. Here you don't have a K max as such, but what you have is a scar center which can be found out either on ImageJ software or on your topographer itself. If you blur out the topography and superimpose it with your corneal image, you will be able to find out the center of the scar and then accordingly decenter your ablation to that position and specifically plan the depth that you want. And here in our case, it exactly matched the area of the scar and the area of the topographic irregularity. And if you look at the topography, the ASOCT before surgery, what we had was this with a differential scar thickness in different regions of the cornea. And basically there was an epithelial irregularity as well. So here we did a trans PTK again with the ablation as shown as previously. And if you look at the post-operative topography, we just ablated 25 microns over the epithelial thickness, but with the application of MMC and with epithelial remodeling over time, what you find is you don't have to ablate actually. If you have a 100 micron scar, you don't have to ablate 100 microns because in a PTK for anterior corneal scar, it's not an aim to actually remove the scar in entirety, but it's to debulk it to an extent that visually it doesn't make any significance further. So if you look at the image in the center in your top part of the screen, so it shows the post-operative topography where you can see that the horizontal coma and the trefoil have significantly decreased. And it is also documented by an improvement in your patient's CDVA as well as the high rod aberrations, the horizontal coma and the vertical coma. So what we have essentially achieved here, which is to be noted, is the spear change in the patient post-operatively is only a 0.25 diopters of hyperopic shift. Normally, if you had ablated, let's say, close to an 80 microns of PTK for a 6.5 or 7 millimeter zone, as you would conventionally do, what you would have is a hyperopic shift of 1.5 to 2 diopter spear, which you would have to address in another sitting by doing a recorrection or a procedure to get the patient back to metropia. But here in a single step, just by ablating the scar region and not disturbing the rest of the cornea, what we have essentially achieved is a single step procedure to get the patient back to 20/20 partial and with a significant improvement in his quality of vision. So this again is a recent publication from our group as a surgical technique in the European Journal of Ophthalmology. We haven't used the word scar Trek, but we have used it for anterior corneal scar removal. So a similar procedure has been described by Shady Awad from the American University of Beirut. So they have used it for other corneal scars as in the spheroidal degeneration, which is at the 5 millimeter zone or the 4 millimeter zone, where you would not normally want to do an ablation for a large zone. Well, you can specifically ablate the areas where you have either a recurrent corneal erosion or a spheroidal degeneration or another anterior stromal degeneration or a scar which you want to treat. You can specifically focus those areas. So the talk until now, if you look at it, most of them have been specifically spoken about in a Schwinn platform, but I do not have any financial disclosures. But this is one system which offers this maneuverability. But I have heard of a joystick PTK mode in the MEL 90 platform as well, which can be put to effect in a similar fashion. But we'll have to try out how it can actually customize the ablations and decrease the area and provide an additional cyclotorsion compensation, because Other people, what they do is they even on a wave light or on a star S4 IR, which does not permit a specific descended ablation, they just ask the patient to look up or down, they ablate. But it's a very crude form of ablation compared to what we have here with the Schwind or what we can try out with the MEL90. And there is another application which I would like to show here, which is called SAVE. So whatever we were discussing before was, trying to ablate more in the region of the cone, the epithelium, which is a Creighton protocol, and which is a modification, which is a Trek protocol. If you looked at what we have to do in a cornea, which is thinner, is something called a SAVE protocol, basically wherein you have to save this epithelium in the region of the cone and ablate the rest. So this can again be possible with your platform, wherein you can ablate. So the red zone, the red ablation you can see is all around the cornea, say 7 millimeter zone, you're ablating the epithelium. And just by entering inner diameter for the PTK that you are planning, you can specifically spare that region for ablation. So this is an interesting option that we tried out a couple of years ago for a set of close to 10 to 15 patients. The patients had a stability in their progression in keratoconus over the next 6 months to 1 year, but the outcomes of the cross-linking as to flattening and epithelial change and the abarometric improvement were not satisfactory, because essentially what you're looking at is something like this. So if you looked at the ultra high resolution SDOCT of these patients who have undergone an SDOCT protocol, the center, the top layer is the top line that you see is the bandage contact lens, and below that you see is that specific area of the intact epithelium which has been specifically saved by your protocol, and the margins of that can be seen where the epithelium is removed, and the BCL is seen on the top. And if you looked at these lines, basically in the initial few days, we were even able to appreciate the hyperreflectance under the epithelium, because basically this is like an epi-on procedure, but it's only for a small area of the cornea the epithelium is on, but for the rest of the area the epithelium is off. But you still have riboflavin penetration in those areas and demarcation zone which starts forming. But in effect, since studies by Hafizi et al. Since the last several years, without oxygen in the central part of the cornea, you are still not going to have an effective cross-linking as well as you would have it in epi-off. And this is something which is very new, which is basically called the next UV protocol, wherein Farhad Hafizi's group has worked on a change wherein basically even if you had a corneal thickness less than 400 microns, you could alter the duration of the fluence which is being delivered onto your cornea, and in effect have a similar level of cross-linking by altering the fluence and the duration. So why I brought this up here is, though this is not an Excimer laser application as such, but this can alter whatever protocols we have already been discussing until now. So if you looked at the first protocol that we had, in summary, the Creighton protocol could be done with, the Athens protocol would require a corneal thickness of at least say 490, 500 microns. And because you would be removing 50 microns of the epithelium average and then ablating around 50 microns. So in effect, before the cross-linking happens, you would need at least a 400 microns of the stroma intact if you have to proceed safely with the cross-linking. In Creighton protocol, you would not require a 500 microns, but you would still require somewhere around 450, 460 microns. But here in the Trek, what you can specifically do is with the similar corneal thickness as you would have suitability for a Creighton protocol only, you can still plan a procedure which is going to give you a visual outcome closer to the Athens protocol and much better than the Creighton protocol with a similar level of ablation as the Creighton protocol. And here, all these protocols are differing so much because of the extent of the fluence time and the duration which we can manage with the existing cross-linking protocols. But with the new next UVA system, if you looked at this, our group has published a new correspondence in the Journal of Refractive Surgery, which gives you a new formula, which basically with the corneal thickness and your keratometric values, which you feed into the calculator, what it will give you is the amount of time that you have to ablate, have the UV fluence on and the specific fluence also. So you'll be able to just feed in your values and ablate it. Sorry, I'm using the word ablation wrongly here. So you'll be cross-linking it for the specified duration which your calculator gives out. So in essence, you will be able to do, even for a cornea which is slightly thinner than, which is suitable for an Athens protocol or for a Trek or for a Creighton, you can still go ahead and do a treatment of stromal ablation and still decrease the fluence and the duration and accordingly do a cross-linking. But as in long-term outcomes are still not there. So at this point of time, if you looked at whatever we discussed, we have the Trek which falls in between Creighton and the Athens protocol in terms of visual outcomes and in terms of the amount of tissue ablated, and it offers an advantage in patients with thinner cornea. The eye Trek is a procedure which helps in patients with very, very decentered cones and very high defocuses, very high myopic errors in the cornea, because you can initially with an intact, what you can do is decrease the spherical and cylindrical errors in the cornea. Say if the patient has initially -10, you with an intact you bring it down to -4, -5, and then the remaining spherical equivalent and the cylindrical and the aberrations can be taken care of by the trick. So the trick is not in essence going to treat all the sphere in the cylinder, and it is not intended to do that like the Athens protocol. But what we can achieve here is an effective aberration control, effective improvement in the corrected distance visual acuity of the patient. And this protocol can be extended, as I showed in the other paper of ours, is scar trick, as in for your corneal, anterior corneal scars, which are up to say 100, 120 microns, and you feel they are not uniformly distributed across the surface area of the cornea and they are in specific quadrants. Instead of updating the entire cornea and looking at hyperopic shift to treat later, you can specifically update those areas of the corneas and save your patient from a second procedure. But still, we require long-term results and more number of patients to be studied on that protocol to be able to be 100% sure as to what would be the change and refractive error after these procedures. And save protocol is something which we are not doing currently, but that is just an option to play around if you have a toy and you can play around with a laser. And I have just not added one thing at the end of what we can do further with the lasers, which is basically we can have fun with the lasers too. And that is the last application of Excimer lasers that we can look at. And with this, I would like to invite questions and have a good discussion on what this topic has brought into the picture. Thank you.
Thank you very much. Is that your party back in Bangalore? How you party there?
Before, it's a BC era, before COVID era.
Okay, before COVID. All right. Well, thank you so much. That was very informative, and I'd love for our other attendees, Erwin, Ruben, Reg, anybody else attending to comment or ask questions. So one question I had is, this is really amazing. It sounds great, but you need some key ingredients to make this happen. So the first is we're getting more and more reliance on epithelial mapping. So let's start with that. What are some of the machines that can do this? How wide the zones you want to epi-map? So can you expand a little bit further on people who are looking to getting into this? What are some of the key aspects of epithelial mapping that we should be aware of?
Yes, so if you looked at whatever epithelial mapping devices exist at this point, starting from before, which could be time domain or spectral domain, most people have shifted to spectral domain OCTs for the epithelial mapping currently. And even for an OptoView or an RTView Avantis, what you can maximum image is the epithelium is up to 5.5 millimeter zone accurately, because the OptoView focuses only on that zone of the cornea, and you'll not be able to image the epithelial changes beyond that zone. So most of the ASOCTs at this point have this limitation, except one new device is called MS39 from CSO Italia company, which can image up to 9 millimeter zone. And that device can give you information about the epithelium and the Bowman's curvature and the stromal elevation as well, because it is the only topographer at this point which has a combination of a Placido with an ASOCT or with a spectral domain OCT. So it can actually differentiate between your epithelium and the stroma, which your other topographers cannot do. So it additionally offers us the 9 millimeter ability to measure the epithelium. But if you frankly ask me about what applications would specifically have, they are very limited, except for peripheral corneal degenerations which you would want to treat, and which anyways not require cross-linking or a procedure like this, which to augment their visual rehabilitation. So 95% of whatever patients we regularly see and who require such procedures we'll be able to map out and get sufficient information from the OptoView or from the Triton or from the existing other spectral domain OCTs. If you're looking at something very peripheral, which these devices do not show you, then the only option at this point is to look at MS39 and to find out the epithelial thicknesses peripherally.
Yeah. So we're waiting right now for the Anterior to develop its epi mapping module, which should hopefully be coming out soon as well. There's a question: what is your experience with corneal haze development after TREC and cross-linking?
Yes, that's so. there is this divided school of thought here as well. So as some people in the world use MMC, mitomycin C after these procedures for keratoconic patients as well, but we have never been doing that because there is already an enhanced apoptosis of the keratocytes which is going on. So we don't do an MMC application after any of these procedures. So only for a scar trek we have been using that. And as far as haze as such is concerned, if you are able to manage the preoperative inflammation of the corneal surface before you take up these patients for a treatment, the haze that you're going to see is very minimal. And our protocol with respect to pre and post operative to prevent haze in these patients has been manifold. So which is which is basically looking at their preoperative ocular surface inflammation. So we also do a tear proteomics preoperatively, and if they have a heightened inflammatory profile, we keep them on a cyclosporin for close to 2 or 3 months before we take them up for procedures. Because in essence, what haze translates into clinically is an effect of the pre-operative existing inflammation subclinically, which drives the conversion of keratocytes into myofibroblasts. So normally you would have keratocyte apoptosis and regeneration, so you would not have significant haze, but you would just have a very minor hyperreflectance in that zone. But if you are having an exacerbated inflammation preoperatively, then you're going to have more myofibroblast transformation and haze. So it's very important to look at, even if you don't have a specific way to assess inflammation, at least gross inflammation, clinical inflammation, allergies, and especially in keratoconus patients, and keeping them on a month or two of cyclosporin before the procedure or trihalube, which can also decrease inflammation in these eyes. And additionally, looking at their vitamin D profiles, because vitamin D is, as you know, is a systemic immunomodulator, and the more the inflammation that happens in the ocular surface or any part of the body, even with COVID, they say vitamin D deficiency causes exaggerated inflammation and causes cytokine storm and more ICU admissions than those patients who have normal vitamin D. So vitamin D as such levels, we usually tend to stabilize them before surgery. If they are less than 10 nanograms per milliliter, we give them a IM shot of vitamin D for a couple of visits, and then we take them up for the procedure. If it's between 10 to 30 nanograms, we either start them on an oral dose of vitamin D, or there are even intranasal formulations which are available to have a maintenance dose. So ocular surface inflammation and vitamin D levels are very important to be stabilized if you have to experience a very smooth transition from a healing process without having haze.
Okay, so can you expand on your reasoning for not using mitomycin C, and what is the proteomix? Is that what you call a proteomix panel that you do preoperatively for ocular surface inflammation?
Yeah, so mitomycin C, to touch upon that at first. So mitomycin C is specifically used in a phase of wound healing, which is between the initiation of injury to initiation of healing. So what happens is, when your epithelial Bowman barrier is breached, you initially have a spurt of cytokines and a spurt of inflammatory mediators that come onto the surface to induce healing, which is a normal process. And mitomycin C specifically helps in decreasing the conversion of keratocytes as a result of this inflammation to myofibroblasts, which basically contract and form a scar. So if you are able to manage your inflammation adequately, your MMC requirement would be minimal. And MMC, what it additionally does is, in addition to cross-linking, which even normally depletes your keratocytes up to a depth of 300 microns in the region of the cross-linking done, and it takes up to 3 to 6 months for these corneas to regenerate in terms of newer keratocytes and basal keratocytes to be formed. If you image them on a confocal microscopy, from the day of cross-linking to the time they regenerate their keratocytes, it takes over 6 months. So MMC is absolutely useful in patients who have normal keratocyte densities, and there, even with an insult of MMC9 on the surface of the stroma, you are still going to hold on and the keratocytes are going to regenerate. But in keratoconic eyes, when the cone is already having an enhanced rate of apoptosis of the keratocytes, you are going to experience a heightened apoptosis, and the time to regenerate is going to be later. And the greater the time it takes, your tissue stability and the strength that you gain out of cross-linking is decreased. So there are, as I told you, there are two schools of thoughts, and some people still have been doing MMC and they find the results to be good in their hands, and they continue to do it. So we do not have long-term outcomes between the two of these to compare which is head-on better to the other. And answering the second part of the question, which is about Sorry, I just forgot the second part.
The panel for inflammatory markers.
Yes.
Pretty
So at this point, there is a standard panel which is being used by the lab there in Bangalore, which has close to 16 pro-inflammatory and 16 anti-inflammatory mediators. So the names of only a few of them are known to clinicians as an interleukin 1, 2, TGF beta, interleukin 10, and other transforming factors, platelet growth factors. So these are known inflammatory factors which are in assets known to clinicians, but the molecular scientists who have been working with more number of factors, they have a greater idea about this. So basically, if you look at the ratio of the pro-inflammatory to the anti-inflammatory cytokine levels on the ocular surface obtained from the tear film, you will be able to find out whether the patient has a pro-inflammatory ocular surface or an anti-inflammatory surface. So if you have a surface which is pro-inflammatory, so in most of these patients, you do not require even a tear proteomics to ascertain whether they are inflammatory or not, because you will be able to find out subtle clinical signs on the ocular surface in the form of a few small P's somewhere in the conjunctiva or in the peripheral corneas, or a little bit of lid margin inflammation. And so you will be able to, in effect, find out only a 10 to 15% of the patients who absolutely do not have any specific clinical signs of inflammation of the surface and still pick up on the proteomics. So in effect, a very good preoperative screening for an MGD, for allergies, for ocular surface changes, for dry spots, for stainings in the periphery of the cornea, and these aspects, and an OSDA score and tear film assessment. So these things can, in effect, 80-85% of the times give you an understanding of whether the surface is pro-inflammatory or not. So it's only a very small percentage that you're looking at, which are subclinical totally.
Okay, thank you. This question that came up here, I want to know if these protocols can be used with an Alcon wave light 500, EX500.
Yeah, so at this point of time, whatever you can do with the Alcon EX500 are only the Cretan and the Athens protocols, because the new stream light which is available with the Alcon, which is a trans PTK mode, you will be able to do a trans PTK for scars. You'll be able to do a trans PTK for your epithelial ablation for a PTK before crosslinking. But the altered ablation profiles of your TREC or iTREC or scar TREC, which have a descended ablation profile, cannot be achieved at this point with Alcon as such.
So then the other question I had for you is with the MS39, and I know I've heard a lot of good things about this particular device, mostly from our European colleagues. Is there any talk on marrying this and integrating it with the Schwinn Amaris system, for example?
Absolutely. So that's something definitely on the cards. The CSO and the Schwinn team have been working on this, and they are trying to integrate a system where you can feed in the data instead of from the Schwinn Cirrus topographer. Instead of that, you feed in from the MS39 the MS39 topographer, and you would additionally have epithelial details as well. So, but that's going to be a few months or years ahead before it comes out into utility.
Okay. Another question is, when do you recommend doing a cretin protocol versus a TREC treatment for keratoconus?
So essentially, after we came up with the TREC protocol, we have absolutely stopped the cretin protocol, because in essence, what we have found out is that for the same epithelial thickness, which is suitable for cretin protocol, all of them are suitable for a TREC as well. The only time we differentiate between whether to do a TREC or not is when we compare it with the topo-guided PRK inclusion criteria. So if the patient has a 490, 500 microns of corneal thickness, epi-on, and if the cone is not very decentered, because that is one other criteria to differentiate whether we choose the Athens or the TREC, is whether you have a very decentered cone or whether you have a relatively centered cone. These topo-guided treatments, which are on the TCAT platform or the Schwinn or the ML90, all of them work very well for a centered cone. They also work for a peripheral cone, but they ablate a lot of tissue, because the amount of tissue consumed for a spherical aberration correction is lesser, but the amount of tissue consumed for a significant vertical coma or a trefoil change is very high. So if you have a decentered cone at, say, the 3 millimeter from the center, you're going to be ablating much more of the cornea in the superior aspect, and the aspect around the cone, areas around the cone. So that's something more damaging to the cornea rather than doing a trick where you would be able to specifically target that decentered cone and ablate that. So otherwise, the confusion for us is only between Ethan's protocol and our trick for centered cones. Otherwise, it's a clear cut approach.
So your TREC treatments are standard of care now for your non-central cones?
The TREC treatments is standard of care for corneas which have at least a 450 micron thickness, because in essence we would still be looking at an epi off thickness of say 390 or 400 with that treatment. And if there is a significant level of myopic shift before surgery, then we either go in for a double ring segments if the cone is centered, or if the cone is decentered, we go in for a single ring segment and then plan a trick. Because that helps a lot in decreasing the lower order aberrations as well.
Okay. Since you only ablate, here's another question. Since you only ablate the cone in TREC, does it improve uncorrected distance visual acuity?
Yes, so uncorrected distance visual acuity also improves as a result of keratometric flattening. So the two things that normally, with the visual outcomes of keratoconus, what is looked at is CDVA and the UDVA, which is, so for a CDVA to improve, you definitely have to decrease the aberration profile, which is done by TREC. And for a uncorrected vision to improve, you have to alter the keratometric profile, which is also done by TREC. So if you looked at normal creatine protocol or a normal Dresden protocol of cross-linking with a manual epithelial removal, you would have 1 to 1.5 diopters of keratometric flattening, and here we have an average of 4 to 4.5. So that in effect gives us a decrease in the defocus in the corneal level, so it improves the uncorrected vision as well.
So now if you have an OCT that's able to give you information on epithelial mapping, if you have your tomographer, what other diagnostic pieces do you need to round out the picture of what information is needed preoperatively to make an assessment of your treatment plan?
Okay, so I would definitely need a topographer and a tomographer which give me the right position of the cone and the position of the K-max. And it is very, very important in these cases to assess the actual position of the K-max instead of whatever the device shows you as well. Because most keratoconic patients, what they tend to do is they try to look over the cone. So it's like, new drivers trying to avoid the obstacles and going around areas which do not have an obstacle. So patients with keratoconus with a slightly inferior cone, they normally do not look through the center of the cornea, they slightly look towards the superior aspect of the cornea. So most of the times you would find in every topographer that you measure, if you already have a spot fixation, spot fixation light for the patient to focus, he's going to focus slightly through the superior part of his cornea. So in that effect, your K-max is usually shown to be more inferiorly shifted. So you have to actually, when you do these scanning for these patients, for the people who do these scans, it is very important to switch off the fixation light and manually look at how the patient is fixating and take the scan. That is one thing. If the cone is very decentered, it doesn't make a difference. It is only for those cones which are subtly decentered towards the inferior where the patients try to look towards the top. And that is one thing. And the other thing that I would need is obviously an epithelial profile. And so OptoView, so what we are currently looking at is the raw values in the OptoView for finding out what is the minimal epithelial thickness that is there on the surface. But with the newer MATLAB processing options that are available, if that option exists, what we can actually do is find out the actual epithelial profile and where the epithelial aberrations change on the cornea from the OptoView images which are transferred to our MATLAB software. What we can recreate a new image of where the epithelial aberration actually exists and target that area specifically. So most of the times these areas coincide, but in cones that are slightly larger or cones that are more peripheral, your OptoView, the assessment of the epithelial thickness in the periphery goes down. So you have to recreate those images with MATLAB in order to be able to find out the exact epithelial thickness and the aberration profile of the epithelium in that zone. But that is something that we have still not been using on a regular basis because it's time consuming. But an OptoView or a Triton or any ASOCT which can give us an epithelial profile with at least a 5 micron sensitivity, because we don't want to juggle around a lot with a difference or standard deviation of more than 5, because in essence this effectively depends on how specific you are with the epithelial thickness in the region of the cone. So if you play around with the 10 microns of change, then your outcomes are also going to be variable.
Yeah. So I think I'm not sure if I mentioned this to you before, but I think what the next step is for us here at least, is as we get our technology a bit more sorted out, to actually have like Ectasia around, so we sit as a group of us here and just look in our screens here and just pull up various cases we've seen over the course of the week and come up with treatment plans. So I think as we get a better understanding of the technology and the better abilities of our Excimer laser, we should be able to, in probably a couple of months, start these rounds where we just kind of go over the week's worth of scans and patients and then come up with plans. So this has all been very fascinating. Vaithees, thank you so much for sharing your experience with us. Like I said, it's been really informative. I think a lot of the questions have been coming out. Okay, one other question. With your TREC data, how long does the corneal flattening last?
Yes, so with the TREC data, we have outcomes which are studied until 3 years. So the paper that we have published is only on the initial surgical technique on TREC. So the outcome as such for 3 years is still not published yet. But whatever we found was that there was a flattening which went on until 1 year, as in most patients. And the interesting aspect is with the eye TREC, the amount of time it takes for the keratometric stability to happen is only 3 months. The reason why this happens is what we do is initially we place the Intax ring and then we go on with the TREC procedure. So when the Intax ring already exists in the cornea, the amount of remodeling the cornea can go through is lesser because your cornea is more rigid than it is normally. So after the Intax is placed, the amount of time it takes for the cornea to stabilize in levels of flattening is only 3 months. So we have in the recent past, what we have been doing is trying to place Intax ring even if the abrasions, even if the spear and the cylinder are lesser before, because in effect what we can do is give a solid prescription, a stable prescription for the patient, either in terms of glasses or contact lenses, right from the 3rd month. Whereas in TREC, we have to keep changing prescriptions every 3 months, because until they stabilize it is slightly difficult for them. But with eye TREC, the outcomes are, the stability indicators are much robust.
Okay, awesome. All right, Vaithees, thank you so much again for your time. Thanks for the attendees. There's going to be a little survey you guys can fill out for, it's been just sent out. And of course, this will be, the recording will be up on our YouTube channel for us to look at afterwards. Thanks again. Have a great day, everybody.